Hello, and welcome to the second webinar in ICA's new speaker series, Navigating IC BPS Conversations with Experts. Today's webinar will feature Dr. Robert Moldwin presenting the pelvic floor muscles, another possible source of pain for the IC BPS patient. We are so excited to have you here with us today. I do have a few housekeeping items before we start. First, you'll note that this session is going to be recorded. And also, when we do questions, in order to ask questions, we ask that you stick to general medical questions and not personal questions. And please use the raise your hand feature in Zoom. You will be asked to unmute yourself. And then when you're not speaking, please be sure to stay muted. You can also ask a question using the Q&A feature. Dr. Moldwin will answer as many questions as he can in our hour-long webinar. We will stop at 5 o'clock Eastern. And please prepare your questions to ask Dr. Moldwin immediately following the presentation. So without further ado, let's begin. Dr. Moldwin is the professor of urology at the Zucker School of Medicine at Hofstra Northwell. He is also director of the Pelvic Pain Treatment Center at the Arthur Smith Institute for Urology of the Northwell Health System. Dr. Moldwin has a national and international reputation as a leader in the field of pelvic pain with special interests in pain syndromes, including interstitial cystitis, bladder pain syndrome, and chronic prostatitis, chronic pelvic pain syndrome. Dr. Moldwin serves on multiple medical advisory boards, including the ICA, and is a past member of ICA's board of directors. Please help me welcome Dr. Moldwin.
Hi there. Good afternoon. Well, at least good afternoon for me. Good morning for other people and all that. And thanks so much for joining me today and all of us today. I am going to try to share my screen here. I think you're going to have to let me share my screen. Okay, there we go. Thank you. Good. And we're just going to go on down here. I'm impressed with how many video screens are on. I would keep mine anonymous. That's me. So hi, everybody again. So the talk of the day is pelvic floor dysfunction. And really, the ICA came to me and asked me, would I like to give a lecture on some topic? And this is something that's been very sort of near and dear to me, mainly because when I entered into the field, which is, gosh, probably about a little bit over 30 years ago, you know, I was interested in this condition, this sort of very rare condition called interstitial cystitis. And then when I started seeing patients, I'm like, and they were coming to my door with these diagnoses, I was like, well, they didn't really seem to have a lot of bladder problems, that most of their problems were really pelvic floor. And then I came to the understanding that many patients just have pelvic floor problems, but many patients have both interstitial cystitis and these pelvic floor problems. So today we're going to go through the some of the basics about pelvic floor dysfunction and how it's really important, I think, for any patient who has ICBPS, interstitial cystitis bladder pain syndrome, to have at the very least a basic understanding of what it is, what types of symptoms can occur from PFD, what type of treatments are available for PFD, because sometimes a lot of the bladder symptoms get better when we treat the pelvic floor. So that said, let's take a look at, sort of start with nomenclature. And pelvic floor dysfunction goes by a whole mess of different names out there that have been out there for probably 30, 40, even 50 years. In fact, even beyond that for some of these terms. Spasm of the pelvic floor, proctalgia fugax, Hinman syndromes, Fowler's syndrome, all sorts of different names. And a lot of this is really based upon the clinician who was examining the patient. So for example, pelvic floor problems can give bowel problems, but not bladder problems and so forth. So the name may reflect that. I tend to use pelvic floor dysfunction, meaning it's because it's a general term. Sometimes I use in my own practice myalgia of the pelvic floor, specifically when myalgia means muscle-based pain. So if I press the muscle and it's in pain, then we tend to use the term myalgia. But you're going to see a lot of different types of terms for this, which I think is often confusing for patients and, in fact, clinicians. Really, again, I want to get into the real basics, and then we'll get into the more specific issues. What are the functions of the pelvic floor? So before we talk about pelvic floor dysfunction, why don't we talk about the function? First of all, it provides anatomical support. The muscles, along with the tendons and the ligaments within the pelvis, hold everything in place. And when there are problems there, all sorts of other symptoms might arise, but we're not going to be talking about those specific issues. We're really going to be focusing attention on functional problems of the pelvic floor. And I don't know if you can see my cursor. The bladder is in the middle. The urethra, where the urine comes through, is in the right. You can see it right here. And the muscles really just straddle that whole area. So no question, you can understand why somebody where the muscles are over tight or spasming might give rise to urinary symptoms. Likewise, they surround the vaginal area, or the prostate itself, giving sexual symptoms. And again, they wrap around, as you'll see in the next several slides, the bowel. And so patients are often plagued with bowel dysfunction. I promised you some other slides showing you some more pictures here of what they look like and how actually complex they are. This is over here by my cursor is the front of your body. This is the back of your body by the sacrum here. You can see the urethra, the vaginal area, and the rectum area. And you can see most of the patients that I see as a urologist in clinical practice are going to have problems or pain associated with this area in the front here. That's not to say they can't also have pain here, but these patients often are seen by tailbone doctors, patients, orthopedic doctors, gastroenterologists for things like chronic constipation and pain around the anus and rectum. So depending on where the muscles are having a problem, you may get different clusters of symptoms, which again, we'll talk about. In the male, we don't want to leave out the men who might be listening and have problems with these muscles at all. Often you can see some of the ones specific to the male. This is called the vulvocavernosus muscle, the ischiocavernosus muscle, and some of these other muscles are very involved in the process of ejaculation. So you can just take a wild guess that when they're spasming, not so much fun to ejaculate. So we'll talk about that again later. And then finally, I alluded to the muscles that are more posterior. And here's your tailbone right over here. This is the sacrum. And you can see all the muscle attachments into your lower back. And it's no wonder why so many patients who have these problems may complain of lower back pain, tailbone pain, pain around the rectum, and so forth. So what are the characteristics? What defines really, because I just told you, well, there's the muscles and they become, quote, dysfunctional. What does it mean from a clinician's perspective? And what does it mean from the perspective of ultimately applying therapies, right? We call this dysynergic. Most of the patients who come in with interstitial cystitis will have something called dysynergic behavior of those muscles with respect to the pelvic viscera, like the bladder. So what do I mean by that? For example, when the bladder squeezes to get urine out, those muscles should be relaxing. Dysynergic, meaning the opposite of synergistic, dysynergic behavior means the muscles are not doing that. They might be tightening when they should be loosening. And then you can have symptoms that arise from that, again, dysynergic behavior. We often see that the muscles, instead of being tight, you think tight muscles, spasming muscles and muscles that are so tender should be tighter and stronger than the average, than they should normally be. But in most cases, these patients have actually muscle weakness. We also see the presence of trigger points, which if you have been, if you're working with doctors who, or clinicians who specifically work with pelvic floor problems, they probably mentioned that term to you. These trigger points are actually like little knots, like one might get a knot in their back. We call it a contraction knot, which is literally a contraction of the muscles in that area. And when they've done very fine needle examinations of these little contraction knots, these trigger points, they see that there are all sorts of different inflammation producing and substances, neurotransmitters that transmit pain information in your nervous system. Not nice things to have, and they're all localized in those areas. We often, when we examine patients, see a twitch response. So when we push in on the muscle actually twitches back at us. And often when we're examining patients, we can often reproduce the pain that the patient has by pushing in on the muscles. And that's a typical part, at least in my practice, of an initial examination. So let's move forward into the symptoms of pelvic floor dysfunction that we very frequently will see in the IC-BPS patients. And many of you look at this list and say, I got everything. You see urinary hesitancy, a decreased force in the flow, the feeling, not necessarily that you don't empty completely, but the feeling that you don't empty completely. Sometimes people feel like they empty, and then all of a sudden, 2 seconds later, they feel like they have more fluid in their bladder. Often patients feel the need to strain and push the last drop of urine out. And on the other end of things, they have constipation. Often this constipation is long-standing. Dyspareunia, which means pain with sexual intercourse, is seen in a large number of patients. Not necessarily because of bladder-based pain, something is actually hitting the bladder, but often because something is hitting the muscles themselves. Just like I would push the muscle, it hurts. Anything else that comes in contact with the muscle, whether it's a vaginal dilator, finger, penis, what have you, that can cause pain as well. Low back pain, as I had mentioned. And interestingly, we did a study looking way back when into patients' histories. Many patients, as little children, had urethral dilations, actually to stretch the urethra out, because in many instances, some of these dysfunctions go back to early childhood. Often they disappear and then they blossom again, unfortunately, when we become adults and actually start to live our lives. All of a sudden, this business starts to hit. In the male, I sort of was leaning towards the female patients, but as you can see on this list, there's also pain with ejaculation. Sometimes the pain doesn't occur at the time of ejaculation. It can occur a day later or 2 days later, and sometimes can be short-lived, but can last for many weeks or longer. There's some reports that pelvic floor problems can also be associated with testicular pain. So, okay, so now I hope you get a basic idea of pelvic floor dysfunction. The muscles are often tender. They're not functioning properly, as the name implies. They may be squeezing when they're supposed to be relaxing, and we can get lots of different symptoms from this. And one symptom, of course, as I mentioned, you can understand why someone might have, a female might have a poor urinary flow rate or urinary hesitancy, because again, as the bladder squeezes, those muscles should relax and let the urine out. If it's starting and stopping and all that business, something must be wrong. And again, often this type of muscular problem is present. Why it's so important in IC is that about 80% of patients who have interstitial cystitis bladder pain syndrome will have some pelvic floor dysfunction present. And often it's quite remarkable, just by treating the pelvic floor dysfunction as a sole entity, how many of what seemingly are bladder-based symptoms can settle down. So that's something very, very important, I think, for everyone listening to understand. And also, of course, we try to get this out to the clinicians for them to understand and to initiate appropriate therapies. There's no question if somebody's getting therapy, let's say a medicine directly into the bladder, what we call intravesical therapy for interstitial cystitis, often anesthetics into the bladder, that's not going to help the pelvic, any pain that's coming from muscle problems of the pelvic floor. It's just going to help the bladder. And if all of your pain or these installations are not working very well, sometimes it pays to take another look, and maybe there's some other pain sources present. To that end, this is sort of a very important slide. This pelvic floor dysfunction I mentioned can coexist with IC, but often coexist with all sorts of other sources of pain that patients might have. Patients who just have vulvodynia, vulvar pain, male patients who come in with something called chronic prostatitis, chronic pelvic pain syndrome. Probably about over 80% of those patients will have some degree of pelvic floor dysfunction as a cause for most of their symptoms. And to leave out therapy directed towards pelvic floor dysfunction is going to lead to probably ineffective treatments, or you're just not getting as good as you need to be. So again, I just wanted to point out the overlap, the similarities between ICBPS and pelvic floor dysfunction, and you can see that they can mimic each other. There are lots of signs and symptoms between the two that are identical. Both can give you urgency and frequency of urination. Both can give you pelvic pain. Both can be associated with pain with sexual relations. And both, interestingly, and probably you could understand this, is both can be worsened by stress. And no question, you can understand why pelvic floor muscle problems can be worsened by stress, because people unconsciously sometimes just are tightening these muscles up when they should be trying to relax them. Now, there are some things that you don't necessarily get from interstitial cystitis: the low back pain, the straining with voiding, the sensation of incomplete emptying. That's more in the pelvic floor dysfunction realm. And as opposed to pelvic floor dysfunction, I see patients when nocturia, that means going to the bathroom a lot of times at night, is not as commonly seen in patients who have PFD. So the next question is, why? Why are they mimicking each other? I'm trying to be a good urologist and drink, which I'll tell you to do later on today. Why are they mimicking each other? One theory behind this is that they both enter the sensation from both areas, the bladder and those muscles, feed into your nervous system in a similar location, and your brain just can't pick up the differences between them. And that's something we see in other organ systems, yet they need to work together. They do function separately. You can tighten these muscles up yourself, obviously, without having a bladder contraction. But in terms of our ability to differentiate a painful bladder and a painful pelvic floor, sometimes it's not that easy to do, and it takes a little more detective work, which we'll get into, to separate the two from one another. Now, this is a very sobering article that I used to give in talks, I guess, back in the 1990s. I thought I'd bring it out today. I don't know if any of you have seen this, but it's an article that was published in the Journal of Urology in 1992 from University of California, San Francisco. And they did something that is very surprising. They actually reported on some of their real complications. And this is a devastating one. They had 4 patients who had chronic pelvic pain. They essentially ended up with removal of not only their bladder, but their uterus, the fallopian tubes, the ovaries, the whole shebang, we call total exenteration. They were now having urinary diversion. And as you can see here, the punchline, and this is no joke at this point, is that they all had persistent pain despite removal of all these organs. And this is a very sad thing, and that's why I put the little stop sign over here, because when one has interstitial cystitis and one presumes all of the pain is coming from the bladder, it's a very, very, if it comes down time to thinking about removing the bladder, there are a lot of other sources of pain that have to be thought about. And one, of course, is the pelvic floor. And obviously, the take-home message from this article was that obviously pain you can think it's from the bladder, but it's not always from the bladder. And we have to think about the pelvic floor as a source of pain, and factor that into diagnosis and treatment strategies before we start doing very major surgical procedures like these. So let's get back to the track. Why, what perpetuates? Why do you even have pelvic floor spasm? And the answer is we really don't know. But we do have some ideas of what keeps the process spinning around. And so, for example, in this slide, you can see, for example, if you have irritable bowel and you're chronically constipated, you're having recurring urinary tract infections, or you have interstitial cystitis and you are miserable and you are pushing that urine out and you are tightening up because you're guarding because it's so uncomfortable down in that pelvis, you are probably going to start to tighten up those muscles instead of relax them. Pushing and straining maneuvers can really be a problem. And when you strain and push and tighten up, you're essentially it's sort of like having a bad back and then lifting a 100 or 200 pound weight. It is not going to make things better. It's going to make things worse. So then you get worse symptoms. And then what happens? You push and strain even more, and it goes around and around as a vicious cycle. So sometimes, in fact, when we deal with the bladder for the IC symptoms themselves, and the bladder settles down and the pain starts to go down and the patients feel a little more comfortable, sometimes the pelvic floor muscles settle down also and patients feel a little more comfortable. But oftentimes we really need to apply therapy directly to those muscles. And I'm going to get back to the whole concept of stress. Stress just keeps the process spinning because, again, what do we do with stress? We tighten up, and often we don't even know when we're doing that. From other perspectives, from the male perspective, again, we start off with a hypertonic pelvic floor. The patients start to get aroused, and they've been this route before. They fear that pain. They know that if they have an ejaculation, now they're starting to hold back and they're tightening up the muscles even more, what we call guarding behaviors. The ejaculation occurs, and then they have really bad ejaculatory pain. And you can imagine this then worsens the next time. There's even more guarding behaviors, more fear of pain, and the pelvic floor becomes even more hypertonic, more tightened and tensed up, and more symptoms. So what ends up happening? Avoidance behaviors. We have guys who just don't even want to have sexual relations. They have worsening of their urological and oftentimes gastroenterological symptoms. And a lot of these guys even present with erectile dysfunction and premature ejaculation. So it's out there. And of course, ultimately, it really boils down, as I'm sure everyone listening this afternoon would agree, everything works down to the poor quality of life. We need to back this business up. We need to take these vicious cycles and, again, spin them in a different direction. Okay, let me see if I can. And there's stress again. I always put stress into a slide. All right, so how do we diagnose pelvic floor dysfunction? I put these sort of things in order in history, physical examination, and other testing. Really, the size of the print is important here because history is the most important. We confirm history and with a good physical examination. And really, other tests are helpful, but they're not they're more confirmatory usually than anything else. And we'll get to some very simple tests that can be done in the clinician's office. Well, of course, I mentioned the symptoms already. So a good history, of course, is the important thing. Do you have IC symptoms, but are you having constipation? Do you push and strain when you urinate? Do you feel like you're emptying the bladder? All these different things are all really important questions to ask. The next part is to do a good pelvic examination in a female, rectal examinations in men, sometimes a rectal examination in the females, but that in general is usually not necessary, but I wouldn't never say never. You can see here, we're looking for points of tenderness in all of these different areas, what we call the levator plate, the superficial muscles of the pelvic floor, and I'll show you again here's one, what's called the which is called the coronal view. Oh, go back there, sorry. There we are. And again, how they hug the urethra, how they hug the base of the bladder. That's quite important. And where we feel the pain, is the pain in the urethra? Is the pain in the vaginal area? Is the pain in the muscles? When we push on the bladder, is the bladder painful? So we're not just aiming to find pelvic floor-based pain, we're aiming to look for other pain generators that might co-occur with the pelvic floor problem. So a patient may have pelvic floor pain, but if we push on the bladder, maybe they have bladder pain also. So we have to dedicate and focus attention, perhaps not just on the pelvic floor, but also, again, of course, on the bladder. When we do these examinations, I just start over here, where often we will feel pain when we even apply a small amount of pressure with one fingertip. There are all sorts of other areas that we can find pain sources. And it's very important that we map these out and that we acknowledge, is it on the right side? Is it on the left side? Which muscle groups are they? Because that becomes important not only for the urologist, urogynecologist, whoever might be seeing you primarily, but also for the other really needed clinicians, the physical therapists who specialize in this area to focus attention on. Here you can see in the male patient, this is the base of the penis, where often a lot of the ejaculatory function starts and continues. You need to have rhythmic contractions, and when these muscles are not functioning properly, again, pain can ensue. One other thing I just want to show you and point out in this particular image, I don't know if you can see these little, I should have colorized them, but these little white areas, these are not blood vessels, these are nerves that supply these areas. And these are important, of course, for sensation, also control of the muscles. And we have to keep in mind that the muscles work with the nerves, and sometimes nerve blocks, and we'll talk about injections into the muscles themselves, can be helpful. When we've done it, we've been looking at this for many, many years. This is just an old study, just that I wanted to get it undusted before I gave this lecture to you. This is a map that we gave patients years ago, patients who had interstitial cystitis, and we asked them to put an X mark on where, apart from your, above your pubic bone, where else do you have pain? And look at all the different X marks. This is a composite of many, what do I see here? About 53 patients. And you can see, of course, the X marks in a cluster around this area, but look at all the lower back pain and the gluteal pain that many of our patients have. Areas that probably, if they're addressed with various ways to relax the muscles and get them functioning more properly, they'd feel a lot more comfortable. Okay, so I'm going to actually skip over this slide. This is just to say how the degree of tenderness in the muscles has a lot to do with the findings of constipation and how poor the flow is and how much urinary hesitancy there is. Now, I mentioned other tests. This is a really simple test that we often give patients in the office. Aside from scanning the bladder and making sure that the bladder is empty to a significant degree, we often ask patients, as we say, pee into a bucket. It's called a Uroflow machine. And I just want to draw your attention to the third line down here. This is time on this axis, and the y-axis up here is how fast the urine's coming out, okay? So it's the flow, the amount of urine that's coming out. So this is flow per second. What we can see over here is the patient pushed, stopped, pushed, stopped, pushed, stopped. It looks like literally looks like a saw. This is not the way it's supposed to look. It's supposed to look like this. So one might hypothesize, and you'd probably be correct, that in between the patient's pushing and pushing, the muscles are contracting over and over and over again and not really allowing for a really effective flow. So flow should look like this. Flow should definitely not have this type of interrupted pattern. All right, so we talked about how one about the nomenclature. We talked about the signs of pelvic floor, how very similar it is to the symptoms of IC, and how the issues we have in trying to pull those two conditions, which may give similar symptoms in many instances, apart, using a good history, physical examination, and even doing some testing in the office on some occasions. Now we have a diagnosis, and how do we treat this particular problem? This is what I tell all patients. First of all, of course, I sort of threw this at you right from the get-go. Patients tend to push and strain when they urinate. That's the last thing you should do. I know a lot of you do not feel like you're emptying the bladder out well. Your flow is not that good. If you listen to the lady or the guy next to you in the bathroom, it's coming out like a fire hydrant, and yours is sort of piddling along. Don't get tempted into pushing and straining. That will just make you worse. The second thing I don't think I've ever put on a slide before is beware of the tight bottom. Often I tell patients to watch your bottom. Basically, what I'm talking about here is that a lot of people sort of live their lives. They don't even realize it, but they're always tight there. It's sort of where they store their stress. And some people, it's just ingrained in them. I always tell people they're sort of hardwired to constantly be tight down below. Also, it's hard to be relaxed when you're in pain down below. People normally start to guard. If you bang your elbow or your toe, the first thing you want to do is cover it up and hold it and pull it in tight. This is not a good type of, we'll call it, behavior to have. By tightening up and trying these protective mechanisms, it's just going to make the problem either never get better, or at worst get worse and worse and worse over time, because again, you have lots of vicious cycles. What I wanted you to watch is this. This is what I constantly see when I'm interviewing a patient in my office. And if you watch carefully, what is this person doing? Constantly see this in my office. And this is this kind of what we call masseter clinching, constantly clinching your teeth together. This can lead to this can lead to TMJ problems, chronic headaches, all sorts of problems here. And the crazy thing is, most people who do this don't even know that they're doing it. Now, why am I telling you about up in the jaw? Because what does that have to do with my bottom? Well, we've done studies that very strongly suggest it does show that of our patients, 75% of those who tend to clench their bottom muscles will be clenching their jaws also. So it seems that there's sort of kind of this global clenching process that many people are afflicted with. And it's important to understand it, because if you don't even know it exists, how are you going to ever treat it? If I tell you I'm going to give you a shot, or I give you a muscle relaxant, or I send you to a physical therapist, and you come out of their offices, or you take that therapy and you go back to those behaviors, guess what's going to happen? You're never going to get better. You're wasting your money. So it's really important to keep these types of, again, behaviors in mind. The next thing, of course, on the list is no constipation. That goes without saying. Your bladder and your bowel are connected neurologically. When you have constipation, bladder starts to not be happy, and so does the pelvic floor. And often, again, pelvic floor tightness is associated with constipation, because what are those patients doing? Instead of blocking their urine off, some of those patients are actually blocking their stool off. More vicious cycles there. So it's important to concentrate on avoidance of constipation. Warm baths, heat seems to be very good. I often tell patients who are really miserable, get in that bathtub twice a day. I tell them to put some either Epsom salts. I like Aveeno, which is a product out there. It's like a little oatmeal powder, not the kind you eat. You put in the bathtub. Skeletal muscle relaxants, so we'll talk about those in a little while, and specialized physical therapy. Those are the basic rudiments, I think, of getting patients better who have pelvic floor problems. But there are more things that can be done, but those are the big boys on the block, or the big girls on the block. Physical therapy, just to do a shout out, these are practitioners there are specialized physical therapists. That's all they do. They have specialized training working with pelvic floor dysfunction of all sorts, not just too tight, as most of my patients have, but also too loose. These are these specific pelvic floor physical therapists will be working with often is something called myofascial. They'll be doing myofascial work. They'll be doing, many of them will be doing something called heel massage, which is pushing in on those muscles to try to stretch them out and get rid of those trigger points that we were talking about earlier in my discussion. This is a specific controlled study that was done. They used these special myofascial physical therapeutic techniques, and they compared it to just global massage. They just went to a massage therapist in your locale, and what they found was significant improvements in the patient's symptoms, what's called GRA, global response assessments, in the just applying myofascial physical therapy compared to the patients who receive global massage. So there's no question that this has become really one of the cornerstones of management, a very conservative management, albeit, of course, it is labor intensive. You have to get to the physical therapist. And the second real hurdle is to find a good physical therapist in your specific community who is well-versed in these techniques. It's not just manual therapy. They may be doing biofeedback with some patients. They may be using vaginal dilators or anal dilators, up to their what their comfort level is and their area of expertise. These little gizmos on the side over here has been affectionately called the wand. So these are used by both men and women so that they can start performing self-therapy. So they get inserted into the rectum or into the vaginal vault, and one can apply pressure and literally give yourself a massage and get rid of those trigger points when you find things are acting up, or just as a routine, really under the guidance of the physical therapists. Other helpful items, behavioral changes, as I mentioned, cognitive behavioral therapy. Sometimes changing gym activities is important. Why is that? Because some of these activities, I'll go to the gym and I'll hear these guys grunting, and clearly that's not you can imagine what they're doing to their pelvic floor muscles when you have to grunt. If you're grunting, that means that you're literally holding your breath, and when you have to lift a weight or you're doing an activity, you're going to have to reflexively tighten up your pelvic floor, which is something you really don't want to do. Some patients are really bothered by bicycles, others are not. You really have to see sort of like dietary changes in IC patients. Not everyone is sensitive to every food or beverage product. So you have to sort of experiment around. But as a good rule of thumb, any exercise where you're going to be engaging those muscles, especially when you're not feeling that great, and tightening them up is not a good thing to do. I often tell patients, even if you're doing a sit-up, but you're holding your breath and you're not doing them properly, you're probably going to need to tighten the pelvic floor muscles. And again, it's no wonder that you'll get a flare after that. One of the gym activities I find really helpful for a lot of people that don't do so much, wreak so much havoc on their pelvic floor often is the ellipticals, because it's more of a fluid motion. Yoga, as you can see here in this picture, whether it's just hatha or vinyasa yoga techniques, can be really helpful. And keep in mind, seat support can be really important too. Not everybody has to sit on a little silicone seat support. Oftentimes, some people need hard seat support. Some people use donuts. Some people find donuts are horrible because everything sort of falls in the middle, and then you have to lift up your pelvic floor to feel corrected again, and ultimately that makes things worse. So you have to play around with different types of seat supports, and I think that's so important. I'm sitting down right now, for an hour with you guys. I'm not getting up. I have a good seat support, but still, it's something to keep in mind. Very important. Muscle relaxants, I mentioned that on the list. Just to cut to the chase, there are a lot of muscle relaxants out there. I listed a whole mess of them on this little list here. The ones that we tend to use a lot of are diazepam and baclofen, but you know, well, you can see all the others. The big problem with muscle relaxants in general is that almost all of them can have a tendency to cause some lethargy. And if they do, if there's fatigue associated with it, or you're depressed, or you're having any other problem, that's not the one for you. You need to either flip over to a different medication, or a different preparation, or a different type of therapeutic strategy. But all the doses usually are relatively low, just because of the environment we live in these days. Diazepam, I think, by many practitioners is sort of slowing down. People are just very concerned about, this is the same problem, of course, with opioids and all these. But again, they do have a role historically, and in most patients who really truly have muscle spasm, I think benefit from something on this list. It should be very well understood that the pill itself is not the cure, okay? Any of these muscle relaxants will hit every muscle in your body. You need to have local therapy, not just this type of therapy, which will hit all the muscles in your body. This takes the edge off. It's not, it's something that needs to be used in a multimodal therapeutic strategy. One option that's really been helpful for a lot of people, and seems to be sort of I think a trend, I guess, in the field, is the use of suppositories, whether it be diazepam or baclofen suppositories. These are all off-label. They're made in compounding labs. We don't know what, any consequences, not that I've seen any, with long-term use. But again, all of these preparations, the idea is to use them, and if best possible, to wean down and hopefully off the medications. So many of my patients, whether they're using suppositories or oral use, will have it at home just in case they have symptom flares, but that's about it. But these are different preparations and the typical doses that are, at least we use in practice. Oh, one last thing about the suppositories. What's the concept behind it? The theory is at least maybe perhaps a lower systemic dose, but again, that's going to be dependent upon whether it's vaginally inserted, rectally inserted, and so forth, whether there's inflammation in the area. There's so many factors that might change how much is absorbed systemically. The other concept, of course, is that you're giving more of a local dose. The idea is perhaps we'll have more localized or muscle relaxation properties by giving it right, so to speak, where the action is. Other useful techniques that have been used, and I usually use these for patients where they've sort of plateaued. They're really doing well, but they're not where they want to be, and we have a little more work to do. And these are different types of trigger point injections, whether you put a needle in, what we call dry needling, just to put it in and out, and hit those trigger points to release those inflammatory mediators I discussed earlier on. We can put anesthetics in, or even Botox into the muscular tissue that's spasming. And the idea is, if you have a trigger point and it is a source of pain, by giving an injection or just sticking a needle into that. And again, one of the concepts of releasing these things manually is we can do it just by rubbing the muscle in those knots specifically. You release these inflammation-producing substances. These substances are also neurotransmitters that transmit pain, and ultimately they're depleted, right? The muscle, these chemicals are released, and then patients feel a little more comfortable. So that's the concept there. These are, when we do this in the office, this is my little kit there. We use bupivacaine, which you can see there is sensorcaine and lidocaine. One's the green is the long, and the blue is the short-acting anesthetic. The needles are very, very skinny. That's a 25 gauge needle. And you can see at the tip of my finger there, and that's how we direct the needles into those spots. Often we'll numb up what's called the pudendal nerve. You can see here, we give a little injection right in here, which numbs up this region. Same thing in men. And then we'll give injections into the muscles directly. As you can see here, we can go directly into this muscle through the vaginal vault. We can go the other way and give injections there. One technique that we've been using for years also, instead of going through the vaginal area, and this is a technique that we only can use in men, is to get to those muscles by giving a little numbing medicine on the skin outside the vagina. The finger is palpating, is feeling the trigger point inside. So my finger is in there, feeling the muscle that's in pain, and we direct the needle directly into that specific muscle where the pain's coming from. So we have different, what we call trajectories that we can use, all different techniques. And the individual practitioners who would ever be applying these would really use the technique, of course, that they feel most comfortable. So you can go a whole bunch of different routes. In men, these are the classic injection sites that we use. Often these top 2 injection sites might be sites that we use sometimes when men have ejaculatory pain, because as you saw in those earlier pictures, there's some, the muscles are in that area that are very responsible for ejaculatory function. Here you can see in use, this is something called an Iowa trumpet. I don't use this. This is usually used by gynecologists, where there's a special, it's a special device that allows the needle to be driven directly into a specific area. And just, again, I just put that picture in more or less just to show you how one clinician might get these, the medication where it needs to be. Botox is another way of doing it. I don't use a huge amount of Botox in my patients because I usually find that, surprisingly, the anesthetics, when they're injected into the muscle tissue, and there are some newer studies actually came out of France recently, that show that you can actually, just by putting an anesthetic into those muscles as what we call a trigger point injection, you can get up to 2, and we've seen up to 3 months or so worth of significant pain relief. But there are these patients who it works, but it's not working as effectively or for a long enough period of time to make it worthwhile. And for those patients, I think it's reasonable to try a Botox injection. Now, many of you know what Botox is. People use it for wrinkles, but also, but the way it works for wrinkles and for even injecting the bladder for overactive bladder is that it's a muscle relaxant. And the idea is by relaxing the muscles and the spasm there, pain will go down. Also, Botox seems to have some effects. It's not its major effect, but it does seem to have some effects even as an anesthetic agent itself. So there are a lot of properties that make it seemingly worthwhile. And as you can see here, this is a relatively recent article from International Journal of Urogynecology. This is what's called a meta-analysis, where they had lots of studies. Well, there aren't that many studies out there to begin with, but they reviewed what they felt were clinically the most important studies that have been done in the field, and essentially found that Botox injections really can significantly reduce the patient's pain levels. And the cool thing about it is, in many instances, up to a 6 months duration. Now, it says here, over here, you can see this number, 2 out of 8 RCT. That means randomized control studies. So only 2 of them had a placebo control, which it just shows you how little work really has been done and the need for more work in this field. This is one study that was done in a randomized control fashion. You can see this is way back from 2006. No real better studies have been done, but they, again, the take-home message of this study was that lots of things: dyspareunia, the pain with sexual intercourse, non-menstrual pain, dysmenorrhea, many of these things, and visual analogs of pain scales were significantly reduced for 6 months compared to placebo. So again, it looks like it's We don't have tons of data. We have lots of clinical experience. I think the biggest problem is obviously having a patient consent to possibly having a placebo when they're already in pain. It's hard to accrue those patients for studies. These injections are not with potential side effects, allergic reactions, nerve block, injuries to the nerves. You can perforate into the bladder or into the rectum, I suppose. You can actually have increase in pain, muscle swelling, things like that. I will tell you, all these things are quite rare. This is what we do tell patients. So this is my important clinical information page. I always tell patients any nerve block or any injection that I can give you or any clinician gives you has the potential. It's very rare. I usually tell patients 1 in 4,000 about, but we can cause nerve damage that does not go away. So the concept here is that the risk is low, the potential benefit in many patients is going to be quite high, so that makes it a worthwhile procedure to do. But this is something every patient has to think about. There's a potential for systemic toxicity, but given the low volumes and the low doses that we give, you don't have to give large amounts, large volumes of these anesthetics to have a really good effect, clinical effect. So again, systemic toxicity is not something we see barely ever. Patients should know sometimes you don't get it right on the first. I usually will try 2 times with my patients. 3 times it's not, I think by 2, I'm comfortable with my injection technique to feel that 2 is probably enough. But if it doesn't work perfectly well the first time, it probably pays to try it again. These are not cures. They only last a certain amount of time. So it's important that you still work with the earlier mentioned conservative methods to deal with pain. Every patient gets, in my practice, walks out the door with a cold pack. So that's really important. I think any needle that goes into any area of the body, think of it like a flu shot. You may feel good initially. It's nice and numb there. I feel great, but you're going to have a little bit of rebound just from the shot itself. So cold packs are a good thing to keep at hand. Other therapies that I think have potential in the future, various forms of neurostimulation and neuromodulation, sort of like the InterStim that many of you know about, not FDA approved for this purpose at all, but at least we do believe that it has some impact on pelvic floor behavior. There are these new units called extracorporeal shockwave therapy units that send directed shock waves, not high, not like you're gonna, not like it's gonna break a bone or anything, but little waves of energy, and they're focused not at the skin level, but at deeper levels, hopefully to shock those trigger points out and let them do their release. So maybe that can get us away at some point from constantly giving injections. It's also thought to increase vascular supply into the area. This kind of procedure has been used for fasciitis, like plantar fasciitis. It's even been used in some circuits for Peyronie's disease, which is a curvature of the penis, and has been used in some clinics in some instances, I know, for erectile dysfunction. E-stim is something that the physical therapists sometimes apply, but it can't be done in a high amperage, but sometimes low amperage electrical stim therapy, whether it be transvaginal or transanal. Interesting technology. It's old technology. I think at some point it might be helpful at some point in the future. Why do some patients just fail? And these are my last slides. These are the things that I got from patients this morning, actually. I'm too busy, I'm working, I just don't have time to do these things. You know, this is unfortunately not a hernia. It's not something that you can stitch up and put a mesh in and, you know, you're ready to rock and roll. It's not that way. It's like having a bad back. I tell patients it's very frequently will come back. Some people have a chronic problem with it, and you know, but we have methods to deal with it, but you have to take advantage of it. You hear the shots are all I need. They feel great after the shot, but the shots don't last very, as long as they'd like, but they're not doing it. They're tightening up in between. They're not, they're not working with any of there's no yoga, there's no, there's no warm baths. They're not. So a lot of this, so the take home message here is it's not easy to deal with this stuff. You need a multimodal approach. It's really important. And although, some things seem to help more than others, it's important to keep in mind, it's rare that, one muscle relaxant pill is going to make you all better. You need to put the time and effort in. One thing that I see a lot is, and this is not just for pelvic floor issues, it's for interstitial cystitis, for vulvodynia. All these many patients come in and they come in 6 weeks later, they're in the office and nothing changed. And I asked them how long, okay, you did this, and this, and how long were you doing it for? Well, it wasn't helping. I said, well, how long did you do it? Oh, 2 weeks. And many of these things, it's not going to change overnight. It's a slow process. Anyone who's had a really bad backache knows it can take a while till things settle down. You're going to have to give it time. You're going to have to put the energy and effort into it. But I can tell you it's well worth it for most patients. I mean, there's no question about it. Sometimes it's on our end, okay? Sometimes we might miss something. If you're not getting better, maybe myself or your clinicians have to take into consideration, maybe the pain is coming from your bladder, maybe it's coming from your bowel, maybe you have overactive bladder is the reason you're constantly going to the bathroom. Maybe we should try you on some other therapies and start moving away from the pelvic floor related issues. So there are a lot of different things that we as clinicians have to think about, especially when somebody is really not doing well with therapy. So in summary, I'll stick around for questions. Don't worry about that. It's out there. It's a common thing, certainly common with interstitial cystitis. Sometimes it's all there just by itself, and sometimes it's misdiagnosed as being a bladder problem when in fact it's not, but it's often associated with IC also. And that's to tease those problems apart is not always the easiest thing in the world, but it's important for you and your clinicians at least to think about these things and applying a targeted therapy. Multimodal, as I told you, that's the way to work with this, not one specific targeted therapy. I think that research, where you have tough time, I told you, it's hard to get patients to be in a placebo group, to say, I'm just going to get a saline shot instead of an anesthetic or a Botox injection. We don't have, aside from our clinical acumen, our ability to do our detective work with the history, work with the physical examination. There's no specific marker for this. We can't do an EMG. I mean, people have tried. I don't think it's really helpful, but you can do EMGs of the muscle. I'm not sure how much help that really is beyond a real good clinical evaluation by someone who works with these conditions. So that's really, I think, an important, it's the good and the bad. And more good here is that there's more clinical awareness amongst multiple disciplines. In fact, right now, I have to say I'm going a little crazy because we do have in my area of New York, a lot of physical therapists who are quite well versed in how to in dealing with patients who suffer from pelvic floor difficulties, and patients are having a real hard time getting an appointment because now all of a sudden everybody it's being picked up by gynecologists, by urologists, and so forth, and they just boom send them right off to physical therapy. And they're a little bit overwhelmed. So oftentimes there's a bit of a waiting list. The problem with just identifying it and sending off to specialized physical therapists is that if you leave out all of these things that I'm telling you this afternoon, at least my afternoon, you leave out the warm baths, you leave out the pushing and straining business, all these different things, you might do well, but you're not going to do nearly as well, or you're not going to have as, I think, a rapid response as you would if you do a lot of these therapies all together. So multimodal care, that's, again, major take-home message today. So with that, I will finish up. If you guys have, I'm sure there are some questions around.
Rob, first of all, I just wanted to say thank you so much for that wonderful hour-long bit of information. And I know we said we were going to stop at 5, and we definitely want to allow people to ask some questions.
Yeah, I'll hang out for another 15 minutes or 20.
Yeah. So we'll tack on another 15 minutes for the questions. And while you were talking, there were several questions that came in through the chat. So if you want to like scroll up to the top of there, you can find some questions. And then also if folks want to use the raise hand, we can do that as well. So
I'm still looking at my slides.
oh,
Should I stop maybe I can stop the share thing? Or can you?
Can you see a chat icon at the bottom of your Zoom square?
I see share. That's all I.
Oh, okay.
Maybe if I just do that and
Maybe if you can
share. Oh, here's the stop share. No, I got a the stop sign there. Okay, got it.
All right, great.
So now you say I have
there. If you scroll up,
if
you scroll up to the top of the chat, there were some questions.
Okay, never mind. Most of these are okay. Why specialize? Oh, why specialize in quotes? Because these are, so the question is why am I putting specialized in quotes when I talk about physical therapists? Because physical therapists are specialized in this area. You really need special extra training to become what I think is a competent physical therapist in the field of pelvic dysfunctions. It's not something I think that physical therapists in their typical training get any special expertise in. That's like asking a primary care doctor to remove a kidney stone. I'm the specialist, so I had to go for extra training for that. So that's what I meant by specialized physical therapy. Okay, let's take a look at another. The quotes, I guess I could italicize it. I don't know. I've been told by my oncology UIN to use estradiol for IC and BPS. How do you feel about this? Okay, so basically estradiol, that has nothing to do with, not a lot to do with pelvic floor dysfunction per se. Topical preparations of estrogen are very helpful for many women who have vaginal dryness or pain. Sometimes these preparations, apart from people who are postmenopausal and have dryness, they're even used in patients who have young patients in their 20s, 30s, or what have you, 40s, who have vulvodynia, this nondescript vaginal pain. I'm not going to really address that specific population, but I think that the value of these topical preparations is that they will decrease vaginal sensitivity, hopefully, sensitivity in a bad way, discomforts there, will improve will decrease vaginal dryness in general. They also seem to have these local preparations, some effect in terms of prevention of recurring urinary tract infections. So on the whole, they're reasonable. There's a lot of controversy that has occurred over many, many years about, oh my gosh, am I going to get breast cancer? Am I going to get uterine cancer, or what have you? And pretty much that's something that's usually a conversation between you and the gynecologist. As a general trend, there is a trend towards using these agents, allowing these agents that are topical agents to allow these things to be used, even in some instances with a past history of breast cancer or ovarian cancer and so forth, mainly because the amount of absorption into the bloodstream is so low. And typical preparations that are given are these medications like these pellets, like Vagifem or Premarin cream. Those are classic medications that are used. But those are usually just discussions. What you should not be concerned about, unfortunately, what they do is they put the same labeling in estrogen preparations like the pills or the patches into the the creams, and it makes it sound like you're going to stroke out, you're going to have, you're going to have a major stroke, you're going to die of a heart attack, you're going to have breast cancer and all sorts of different things. And they're completely different, hazard risks. Okay, let's go on to, but again, these are individual choices and discussions between the clinicians and patients. I was told these Botox injections can sometimes cause the inability to void. Okay, so Botox, that's a great question. So Botox is given as an injection into the bladder. Injections into the pelvic floor and any of these things, as I told you, even suppositories, they are not FDA approved for this purpose. So yet we do them off label. And we seem to have improvement in many patients, and we've been working with them, and people obviously, as I mentioned, have done quite well, at least in our experience. But if you give them but when it's given into the bladder for overactive bladder, okay, that's bladder that's squeezing, you may have urinary incontinence, what's called urge incontinence. It can calm the bladder down, and then your symptoms settle down. Obviously, the leakage episodes decrease, the urgency and frequency may decrease, and patients are happy. It is possible when you give it into the bladder, probably about 6 out of 100 people, at least that's the number that's out there, will have difficulties with what's called urinary retention. You can't urinate properly. And in fact, so some patients will need to catheterize themselves, and that would be a big problem for many of our patients. And they have to be willing to do that if they're going to have that therapy. So the risk is low, but it's still not zero. Now, if we now move to the pelvic floor injection, so now instead of giving anesthetics, we're giving the Botox injections into the muscles of not of the bladder, but of the pelvic floor. We have not had significant problems with that, except for one patient. We did have a patient a bunch of years ago. We were using higher doses of Botox, or what's also called botulinum toxin A, because there are different preparations in different parts of the country and globally as well. We were giving 300, now our typical dosing is 200 units, but we still don't exactly know why that occurred, because Botox usually stays where you put it, doesn't go into the bladder after that. But aside from that, we've, knock wood, had some very good experiences, and we have not had that problem. One problem we do tell patients about, it's if we're giving injections way back in the towards the closer muscles that are closer to the anus, there's always a possibility to relax the anal sphincter, where patients might pass gas when they don't want to, not happy about that, obviously, or even have some fecal soilage. So those are potential problems on that end of things. But we generally are not giving our injections in those areas, so consequently, we just have not seen that. Okay. Oh, so Dr. Robert Evans, one of my best buddies, has done trials on PEMF mats, and I'm trying to remember what that acronym is for. But essentially, these are it's an electromagnetic frequency waves that go through. They have mats available for them. I don't have an opinion because I don't have any experience with them. I wish I did. I should have added that. And thank you for that question, because it's a question and a comment at the same time. Would that potentially have some value? Maybe just to sit on it? Maybe. That doesn't sound unrealistic. Any conservative strategy like that, I think, is worth a shot. The biggest problem with all these new technologies is that when the companies put them out there, they're not FDA approved for pelvic floor dysfunction per se, or what have you. And then it's some crazy amount of money to purchase the machine. And then, of course, it's not covered by insurance. And then the cost is passed off to the patient. And one thing that really I just hate to see is patients spending huge amounts of money for therapy that's unproven with the hope that maybe it will be helpful. Can be very, very frustrating experience. But yeah, as far as that from a hypothetical perspective or theoretical perspective, it sounds like I should add that to my bullet list for sure. All right, so let's take a look here. Pulsed electromagnetic frequency. Thank you. I forgot that. I was actually at his lecture in Florida where he gave a wonderful talk on that. My physical therapist recommended blowing on a balloon in order to release urine from my bladder. It works for me. Cool. All right. Well, that's an interesting idea. I'm presuming that is a way to distract you. Lots of people do all sorts of interesting things and I'm sure many of you notice that your symptoms might actually settle down quite a bit when you're distracted at work. You know, you have a task to do. Oh, you got to meet this deadline, blah, blah, blah. And then you realize, oh my God, in the last, 20, 30 minutes, an hour, I haven't actually thought about my bladder. I've been so invested in this. And it's because essentially, it's a lot of that has to do with brain, processing information. Your brain can only handle so much information coming through. That's why I'm sure many of you who suffer from multiple pain conditions, lower back pain, migraine headaches, and then you just bang your elbow, the last thing you're probably thinking at that point is your bladder. So I think part of that is distraction. I have some patients that literally tap their belly. They just concentrate on the tapping when they do it. Allows them to relax up a little bit better. And I think these are good techniques, actually, that many of the psychologists, cognitive behavioral people, and psychologists, specialized psychologists, work to help people divert attention. The only other thing I can think of, I don't think that would be when you blow up a balloon. You're actually, hopefully, you're not tightening up your pelvic floor. That's not a good thing to do. If you're blowing up a balloon and you're putting pressure down there to try to get urine out, I don't think that's a great idea. I think probably if it works, again, it's probably working on the basis of getting you thinking about other things. Myrbetriq. So there's a question on Myrbetriq. Again, that has nothing to do with pelvic floor. If Myrbetriq is working for you, I would bet you and it really helps a lot. It ain't your pelvic. See, that's one of the things that's quite interesting. Certain medicines and certain therapies work on one thing and they definitely don't work on others. So if you think all your problems are pelvic floor and you're getting better on Myrbetriq, chances are you may have some overactivity of the bladder. That's at least the concept there, and to think about that as another avenue of care, right? So,
Rob,
yes.
Can I just divert you to our hand raisers? We have
Sure.
Debbie,
Sure.
who I think raised her hand first. If you want to unmute yourself and ask your question. Hi,
Debbie.
Hi, thank you for this. Was really great. I wrote it in my question also in the sidebar there because I wasn't sure if you were going to get to the hands, but I was wondering, number one, how do you locate yourself a qualified physical therapist that knows this stuff? Because interstitial cystitis and pelvic floor seems like it's just a rough one to find anybody who knows anything. And then also, I have had lower back pain, chronic as well as interstitial cystitis for a couple of decades. And so it's interesting that you're saying that there is a correlation with the back pain, but the back doctor, the orthopedic surgeon, is saying I should do physical therapy to strengthen my core. But isn't that going to tighten the pelvic floor muscles if I'm doing those kind of tightening exercises?
Okay, so I'll just apply this. So basically, let's talk about finding physical therapists. This can be tough. I mean, in our area, they're all over the place. So it's really not it's just going through I don't know if there's a phone book anymore, but Googling your area and physical therapy. I look up physical therapists in pain. You'll probably find definitely some takes. There was, and I wish I had it with me, and my fault. There is a website for you may hear my dog in the background. Sorry about that. That you can go to, but I don't know if it's on the ICA website or we can get that for you. But I know there are some websites specifically with like a registry for physical therapists who work specifically with pelvic pain. Up there is somebody putting it out there. Oh, that's the website. Okay, that's the IC website. As far as when you're doing your research, the very first thing I would ask before you make an appointment, do you have physical therapists that specialize in pelvic pain? End of story, okay? If you have, pelvicguru.com from Linda. All right, great. But I would ask if you have someone that specializes in pelvic pain. That's all you have to do. And then, assuming they have someone there who really is knowledgeable about this, the next thing that the first exam is the most important. In my opinion, and as a general rule of thumb, if they do not do a pelvic exam on your first visit, don't go back. Because that is part and parcel of figuring out what the problem is, right? That's where the muscles exist. They can work on the outside. It's not to say they shouldn't do an external exam and look at, see what your mobility is and all these different facets of what they're so expert in, but they do need to evaluate those internal muscles. There's no other real good way to get to them.
So you're talking about kind of like a gynecological exam. If they don't do that.
Yes, well, I wouldn't even call it, I got to tell you, in my experience, unfortunately, gynecologists don't always do an examination of the muscles. They're, the speculum goes in, the swabs go in, and I think that I think nowadays, perhaps there's more attention being paid in their training, especially with the female who comes in with pelvic pain and perhaps sexual pain and all that. But if I very frequently ask, because almost all my patients have a gynecologist, and they're like, they never did that. We use a Q-tip to examine sensitivity of the vulvar area. Those things are done by a wonderful group of gynecologists, but unfortunately not a huge number of them are all that, they just don't do it. It's not just part of what they do. I wish I didn't have to say that, but it still does occur. People who are probably more facile at that or have that embedded in their training are I'm a urologist, but there are urogynecologists who, and I'm a joint appointment with urogynecology at my facility. We make sure their fellows are well-trained in a good exam, and when they get out there, that's what they should be doing. To get to your second question about different types of physical therapists. So the reason I like that question is because, and I'm making it a broader question, we have a lot of patients who have low back pain. Now, low back pain is not necessarily called by pelvic floor dysfunction. You're going to slip, you can have a disc problem, all sorts of different things. But what the orthopedist told you is 100% true. You do need to pay attention to physical therapy. They have stretches for you. They have manipulations that they would do on you. They will apply heat as well. They will, but you're right. Eventually, the concept is to build up your core to support your lower back. So you say that's different than what I was saying about the pelvic floor, and that's exactly correct. The pelvic floor musculature, we like it to be relaxed, and there is some discordance there between those types of therapeutic approaches. And that's why it's important for those types of physical therapists to actually talk to one another so that that one therapist doesn't mess up the work of the other physical therapists.
That's exactly what I was wondering.
It can be an issue. I mean, you know what a perfect example is? I have patients, I didn't get into the anatomy of the pelvic floor, the structural function of the pelvic floor, but we have a lot of patients, for example, who have what's called urinary stress incontinence. They cough, they sneeze, and they leak urine. And one of the classic exercises that are taught to those patients is, many of you have heard of them, are called Kegel exercises. They are there to tighten. You're going to learn how to tighten that pelvic floor up and exercise. That's the last thing I would tell one of my patients to do. But what happens if they have pelvic floor problems from pain and dysfunction, but they also have, stress incontinence as well? What do we do? How do you manage that? That's when you have to really look at the patient as a as a whole. You know, you have to say, listen, you have to make some hard decisions here. And many of my patients would, you know, I usually tell my patients who have really bad spasm at the same time, you're not going to be able to do Kegels right now. You know, maybe sometime in the future, but now is not the time to be exercising muscles that, you know, when I just touch them, you know, with a small amount of pressure, you know, you're jumping off the table. How are you going to do Kegels? How's that going to, you know, it's going to make you worse. And that's what we hear, you know, that's the feedback when the first, you know, probably the first week of practice when I was a urologist, you know, looking in, seeing patients. It does not help. It usually hurts. I'll tell you another interesting thing. In the AUA, the American Urological Association guidelines, there's a specific endorsement against Kegel exercises and an endorsement for what is called reverse Kegels. Learning where the muscles are, you can tighten them up to try to recognize where they are, but after that, you should be working on relaxing the muscles, not strengthening them, at least not at first, right? Okay. The same thing applies. Maybe at some point in the, think of it like your back. When your back is a mess, what are you going to do? Strengthening exercises? I don't think so. You're not getting out there and doing sit-ups and you know, and crunches and this and that. That's not what you can even think of doing. That's the last thing you would think of doing. Once you start to get better and you're rehabbed and you're feeling, you know, like a little bit back to yourself, that's when you can start doing more of the exercises in the area. And so I'm not saying, you know, an IC patient could never do a patient with pelvic floor-based pain could never do squats in the gym anymore, but not when you're in my practice and feeling crappy. I would probably tell you to avoid those kinds of maneuvers.
Okay, perfect. Thank you. Thank you so much.
Pleasure.
Rob, thank you so much. I think we have come to the end of our time today, but that was fascinating. Your talk was fascinating. I'm so glad we were able to help answer most of our questions. If for the rest of you, if you found this event to be of value, please consider joining us for future webinars and share with your community. We are excited to announce next month's webinar with Dr. Tony Buffington. He will be talking about uncovering social factors in chronic primary pain conditions, lessons from our feline companions. Watch your email for more information. Once again, I just really want to thank you so much, Rob, for all of your knowledge and expertise. And thanks to all of you for joining us today. Have a great day.
Okay, bye-bye now.
Bye.